Welcome. In this session, we are going to continue with our discussion on the infranuclear disorders of eye movement. And in this session, we are going to discuss the lesions of the extraaxial or the peripheral part of the cranial ocular motor nerves. And this portion of the cranial ocular motor nerves lie in the subarachnoid space, the cavernous sinus, and more distally within the orbit. Starting with the lesions in the extraaxial portion of cranial nerve 3, when encountering a patient with CN3 lesion, it is very important to clinically distinguish whether the CN3 lesion is complete or partial and whether it is pupil-sparing or pupil-involving. In a complete CN3 lesion, all the muscles supplied by the third cranial nerve are involved and paretic, whereas in a partial CN3 lesion, only few of the muscles supplied by the cranial nerve 3 are paretic and the remaining muscles appear functionally normal. In a pupil-sparing third cranial nerve palsy, the sphincter pupillae are not involved and the pupil does not appear to be dilated and reacts normally to light. Whereas in a pupil-involving CN3 lesion, the sphincter pupillae are involved, the pupil is dilated and the pupil does not react normally to light. This characterization of a cranial nerve 3 palsy is crucial since it indicates the likely lesion and the urgency of workup and management for a patient with cranial nerve 3 lesion. In a complete CN3 palsy, the involved eye is deviated outward and usually downward. Along with that, there is an ipsilateral complete ptosis. This picture does not show a complete ptosis so as to show the position of the deviated eye. The eye takes up this position because all the muscles supplied by the third cranial nerve are involved in a complete CN3 palsy. As the medial rectus is involved, there is an inability to adduct. As the superior rectus and inferior oblique are involved, there is an inability to elevate the eye, and as the inferior rectus is involved, there is to some extent an inability to depress the eye. The remaining two extraocular muscles, lateral rectus supplied by 6th cranial nerve and superior oblique supplied by the 4th cranial nerve, are spared in a 3rd cranial nerve palsy. Because of the intact lateral rectus muscle, the eye is deviated outwards, and because of the intact superior oblique muscle, the eye is infraducted to some extent. The pupil in the affected eye may or may not be involved. This picture shows a pupil involving 3rd cranial nerve palsy, and an associated loss of accommodation may or may not be present. Here we must remember that to judge the completeness of a CN3 palsy, we do not take into account whether the sphincter pupillae and the ciliary muscle are involved or not. To determine the completeness of a CN3 palsy, we only take into account the remaining 5 muscles supplied by the third cranial nerve. In a partial or incomplete CN3 palsy, since only few of the muscles supplied by the third cranial nerve are involved, the above features occur to variable degrees, and the pupil may or may not be involved in a partial or incomplete CN3 palsy. In a patient presenting with a cranial nerve palsy, it is important to establish whether the nerve understudy is the only cranial nerve to be involved or whether the other nearby cranial nerves are also involved. So in a patient with a third cranial nerve palsy, to establish that the third cranial nerve palsy is the only cranial nerve to be involved, we have to check for intactness of the function of the 4th cranial nerve, the 6th cranial nerve, and the 5th cranial nerve. In a patient presenting with a picture of a third cranial nerve palsy, checking for the function of the 6th cranial nerve and the 5th cranial nerve is straightforward. If the abduction is intact, 6th cranial nerve function is intact, and if the corneal and facial sensations are intact, 5th cranial nerve is also intact. However, checking for the 4th cranial nerve function in a patient presenting with a third cranial nerve palsy-like picture, we have to establish intact intorsion when the patient is attempting infraduction by observing a conjunctival vessel. When the patient attempts to infraduct, the superior oblique is the only muscle to act because the inferior rectus is palsied, and the primary action of the superior oblique being intorsion, the eye also intorts. Coming to the next important criterion to determine in a patient with a third cranial nerve palsy, that is whether the pupil is involved or not. In a pupil-sparing third cranial nerve palsy, the sphincter pupillae is not involved, the pupil is not dilated, and the pupil reacts normally to light. Pupil-sparing complete CN3 mononeuropathy is almost always benign, and it results from a microvasculopathy which is associated with systemic factors such as hypertension, diabetes, and hypercholesterolemia. So this is a very important statement to remember, that if an isolated CN3 palsy is both complete and spares the pupil, it is almost always benign. And the only important exception to this statement is in elderly individuals, in which case this kind of a presentation may be associated with giant cell arteritis, which has to be excluded with ESR, CRP, and platelet count evaluation. A pupil-sparing partial CN3 palsy should not be considered benign. So this is also a very important statement. So a partial CN3 palsy or an incomplete CN3 palsy, even if it does not involve the pupil, that means the pupil is not dilated and reacts to light, it should not be considered benign, because the pupil can become involved later and a close follow-up is mandatory, and usually if the pupil is to become involved, it gets involved almost always within 1 week of onset of the partial CN3 palsy. And neuroimaging is indicated in a partial CN3 palsy even if it spares the pupil to rule out compressive lesions. The most important being aneurysm of a posterior communicating artery, the most important etiologic implication of a pupil-involving third nerve palsy. In microvasculopathy, there is sparing of the pupil, because in a microvasculopathic infarction, the center of the nerve is relatively more affected, but the periphery of the nerve, which contains the pupillary fibers, has good collateral supply and is relatively spared in a microvasculopathic lesion. And in a pupil-involving CN3 palsy, we find a mid-dilated pupil which is not reacting to either light or near, and the associated extraocular muscle or lid involvement can be either partial or complete. And the most common cause is a compressive lesion, most importantly an aneurysm of the posterior communicating artery at its junction with the internal carotid artery, and this compresses the adjacent pupillomotor fibers which are located superficially in the dorsomedial aspect of the cranial nerve 3, and this is a true neuro-ophthalmic emergency. Since there is a high mortality rate with rupture of an aneurysm with subsequent subarachnoid or intracerebral hemorrhage, an urgent neuroimaging is indicated in a pupil-involving third cranial nerve palsy with magnetic resonance angiography, computed tomographic angiography, or catheter angiography to detect an aneurysm. However, if these imaging studies turn out negative, we have to consider other compressive lesions, and for that an MRI with a gadolinium contrast needs to be done. These other compressive lesions causing a third cranial nerve palsy involving the pupil usually also has other neurological signs and symptoms, and they include tentorial herniation of uncus of the temporal lobe from a large supratentorial hemispheric intracranial space occupying lesion. So a hemispheric SOL can cause herniation of the uncus and thus compressing on the third cranial nerve. And in this situation, the pupil is usually the first to be involved in the resulting CN3 palsy. Cavernous sinus lesions may also involve the pupil, and lesions of the midbrain involving either the nuclear or the intraaxial portion of the third cranial nerve also involves the pupil to the same extent as extraocular muscles or the lid. A rare entity called ophthalmoplegic migraine also involves the pupil, but it is a diagnosis of exclusion, and this diagnosis can only be entertained when we have excluded both a possible aneurysm and also other compressive lesions. Now there are two caveats as regards a CN3 palsy. 20% of microvasculopathic CN3 palsy may have a mild involvement of pupillomotor fibers, resulting in an anisocoria, that is a difference in the sizes of the pupils between the involved and the uninvolved eye, and as a rule this anisocoria or the difference in sizes is less than 1 mm. And the second one is A patient presenting with an isolated mydriasis in the absence of other CN3 signs, that is signs of extraocular muscle or lid involvement, both at presentation and follow-up, almost always indicates a localized pupillary lesion, such as Addy's pupil, traumatic mydriasis, or a pharmacologic mydriasis. So in a patient presenting chiefly with a dilated pupil, it becomes very important to rule out subtle involvement of either the extraocular muscle or the lids, and a subtle involvement of the extraocular muscle can be confidently ruled out with a Maddox rod. And if we find involvement of the extraocular muscle in a patient presenting predominantly with a dilated pupil, that changes the course of management for that patient. In a divisional third cranial nerve palsy, either the superior division or the inferior division of the third cranial nerve is involved. If only the superior division is involved, only the superior rectus and the levator palpebris superioris muscles are affected, and if only the inferior division is involved, only the medial rectus, the inferior oblique, and the sphincter pupillae are affected, to the exclusion of the superior rectus and the levator palpebris superioris. And divisional third cranial nerve palsy usually arises from compressive lesions in the anterior cavernous sinus and or the posterior orbit, such as an ophthalmic artery aneurysm, which may cause a superior division compression. Microvasculopathic lesions and giant cell arteritis may also involve only one of the two divisions of the third cranial nerve, and rarely a focal lesion in the brainstem may cause a divisional third cranial nerve palsy, because as we have seen that a functional division of the third cranial nerve may exist as proximally as the brainstem. So in a divisional third cranial nerve palsy, initial imaging modality should be an MRI with contrast and fat suppression to rule out lesions in the anterior cavernous sinus and or the posterior orbit. Another important entity to discuss in cranial nerve 3 palsy is aberrant regeneration of the third cranial nerve, and this happens during regeneration of axons following a neuronal injury, resulting in a synkinetic phenomena in which there is a co-contraction of muscles which are innervated by the third cranial nerve. What is important to remember is aberrant regeneration can occur after a compressive, traumatic, or a congenital lesion of the third cranial nerve, but it never occurs after a microvasculopathic injury of the third cranial nerve. The synkinesis occurs because the regenerating fibers innervate muscles other than those which they innervated prior to the damage. Aberrant regeneration occurs only with the third cranial nerve among the ocular motor nerves, because the third cranial nerve innervates multiple muscles. And aberrant regeneration does not occur after lesions of the fourth cranial nerve or the sixth cranial nerve, because they each innervate only one muscle. And aberrant regeneration occurs because the lesions causing the aberrant regeneration damages the glial covering, segregating the fibers from each other and thus allowing the regenerating fibers to cross over from one branch to the other branch of the third cranial nerve. Aberrant regeneration of the third cranial nerve can manifest as an elevation of the lid when the patient attempts to adduct, as an elevation of the lid when the patient attempts a downgaze, or miosis of the pupil when the patient attempts either to elevate the eye, depress the eye, or adduct the eye. Or there may be co-contraction of the vertically acting muscles causing globe retraction. So we find that in aberrant regeneration of the third cranial nerve, there is no abnormal movement when the patient attempts to abduct, because the lateral rectus muscle is not supplied by the injured third cranial nerve and is not involved in regeneration of the injured third cranial nerve. In primary aberrant regeneration, there is absence of a preceding manifestation of a third cranial nerve palsy, and this usually occurs with a slowly growing lesion such as a meningioma or a carotid aneurysm within the cavernous sinus. After discussing third cranial nerve palsy, we now come to extraaxial fourth cranial nerve palsy, and for discussing the symptoms and signs of a fourth cranial nerve palsy, we will take into consideration a situation where there is a right fourth cranial nerve palsy, and a patient with a right fourth cranial nerve palsy will complain of oblique diplopia, worse with contralateral left gaze and ipsilateral right head tilt, as well as with down gaze. So The diplopia is worse when the patient looks to the left side and when the patient tilts his head on the right side. And this can be more easily appreciated with a double Maddox rod test. In a double Maddox rod test, a white Maddox rod and a red Maddox rod is placed vertically oriented in front of the left eye and the right eye respectively, and this is what a patient with a right fourth cranial nerve palsy will perceive. This occurs because the right fourth cranial nerve supplies the right superior oblique muscle, which is both an intortor as well as a depressor of the right eye. And if the right superior oblique is palsied, then the right eye will be hypertropic as well as extorted. And if the right eye is hypertropic and extorted, the image seen by the right eye will appear to be intorted and shifted below the image seen by the left eye. To reduce the diplopia, the patient assumes a contralateral head tilt and a chin down posture. So with a right superior oblique palsy, the patient will assume a left head tilt so as to reduce the diplopia. And when we perform the Park-Bielchowski's test with or without a Prismbar alternate cover test, we will find an ipsilateral right hypertropia in a right fourth cranial nerve palsy. And this right hypertropia will increase in left contralateral gaze and will also increase in right ipsilateral head tilt. So the hypertropia increases on examination in the same positions of the eyes in which the diplopia increases. One thing to note is that a contralateral gaze and an ipsilateral head turn are equivalent when we consider the position of the eyes in the orbit. We also find X cyclotorsion of the affected eye. As we have said, the superior oblique muscle is primarily an intortor of the eye, so there is X cyclotorsion of the affected eye when the superior oblique is palsied, and this can be most easily detected with a double Maddox rod and ophthalmoscopy. And the ocular movements are usually found to be normal. In the adducted position of the eye, the superior oblique muscle is primarily a depressor of the eye, but only some of the patients with fourth cranial nerve palsy show limited infraduction in an adducted position of the affected eye. So coming to the causes of a fourth cranial nerve palsy, the most common cause of an isolated fourth cranial nerve palsy is traumatic, particularly a closed head trauma. And a traumatic fourth cranial nerve injury occurs in the decussation at the superior medullary velum on the posterior aspect of the midbrain. And when we diagnose an unilateral fourth cranial nerve palsy in a patient with a history of a head trauma, we should also exclude a bilateral involvement of the fourth cranial nerve. And this bilateral involvement of the fourth cranial nerve is often asymmetric. And the features of a bilateral CN4 palsy is a left hypertropia in right gaze and a right hypertropia in left gaze. This does not happen in a unilateral CN4 involvement. Also, there is X cyclotropia more than 10 degrees in a bilateral CN4 palsy. And we also get a large V pattern esotropia. So these are the three features of a patient with a bilateral CN4 palsy as compared to a patient with an unilateral CN4 palsy. A crossed hypertropia and X cyclotropia more than 10 degrees and a large V pattern esotropia. Apart from trauma, the other important cause of a fourth cranial nerve palsy is congenital, and it is usually said to be due to an anomaly in the trochlea or the superior oblique tendon. And the patient usually assumes a chronic head tilt on the contralateral side, and this may be detected in old photographs of the patient. And the patient complains of diplopia only in adulthood, when the vertical fusion amplitudes decrease. However, benign neural tumors of childhood should be excluded in this situation. Fourth cranial nerve palsy can also occur from other causes such as a microvasculopathy, giant cell arteritis, or a compressive lesion. The differential diagnosis of a fourth cranial nerve palsy is a skew deviation. In a skew deviation, there is vertical deviation between the eyes, and this results from a supranuclear cause. In a skew deviation, unlike in a fourth cranial nerve palsy, there is intorsion of the hypertropic eye. In a fourth cranial nerve palsy, the hypertropic eye is extorted. And in a skew deviation, this hypertropia decreases in supine position. but in a fourth cranial nerve palsy, the hypertropia which we detect does not decrease in supine position. Now we come to an extraaxial sixth cranial nerve palsy, and this is the most common isolated mononeuropathy among the ocular nerves, and the symptoms and signs with which the patient presents is a horizontal diplopia. In a horizontal diplopia, the two images seen by either eye are separated horizontally, and the separation increases on ipsilateral gaze, and the separation also increases in distance vision as compared to near vision. To reduce the diplopia, the patient may assume an ipsilateral face turn, and on examination we find an ipsilateral abduction limitation and esotropia increasing on ipsilateral gaze. So in a right-sided sixth cranial nerve palsy, the right lateral rectus muscle is weak, and when the patient attempts to look towards the right side, there will be limited abduction of the right eye, whereas the adduction of the left eye will be normal. As a result, when the patient attempts to look towards the right eye, the esotropia of the right eye will increase, and the patient will also complain of worsening of the horizontal diplopia. The diplopia is also less when the patient converges, because when both eyes converge, both the medial recti are activated and both the lateral recti are relaxed, and as the lateral recti are relaxed, their imbalance will be less prominent. Microvasculopathy is the most common cause of a sixth cranial nerve palsy, and a microvasculopathy, as we have seen, causes an unilateral isolated mononeuropathy. Trauma and raised intracranial tension may injure the sixth cranial nerve either unilaterally or bilaterally, and this occurs at the Dorellos canal, and this Dorellos canal is near the petrous apex, and it is at this place that the sixth cranial nerve is fixed, and the sixth cranial nerve takes a sharp turn from an upward course to a forward course at the Dorellos canal and is vulnerable here to injury from trauma and raised intracranial tension. And a sixth cranial nerve palsy after a minor head trauma may indicate a pre-existing compressive lesion. So if we encounter a bilateral sixth cranial nerve palsy, we must always exclude a raised intracranial tension. Cerebellopontine angle tumors may also cause sixth cranial nerve palsy, particularly acoustic neuroma and meningioma. And lesions in this site may involve also the fifth cranial nerve causing facial and corneal hypostasia, the seventh cranial nerve causing facial palsy, and the eighth cranial nerve causing auditory and vestibular signs. So at the cerebellopontine angle, fifth, sixth, seventh and eighth cranial nerve may become involved. The sixth cranial nerve can also become involved with petrous bone inflammation, and this usually arises from middle ear infections in children and is called Grady-Negos syndrome, and it usually also involves the fifth cranial nerve causing facial pain and may also involve the seventh cranial nerve. So fifth, sixth and seventh cranial nerve can become involved in this situation. The eighth cranial nerve is usually spared by a lesion at this site. Compressive lesions can also affect the sixth cranial nerve, and tumors near the clevus on the posterior aspect of the sphenoid bone can affect both cranial nerve 6. Recurrent painful ophthalmoplegic neuropathy or RPON was previously known as ophthalmoplegic migraine. It usually has an onset in early childhood with a unilateral headache followed by an ipsilateral neuropathy, almost always a third cranial nerve palsy. So it starts with a headache which precedes the diplopia, and the diplopia may occur as late as 14 days after the onset of headache. The headache usually becomes more severe before the ophthalmoplegia sets in and is usually constant and retroorbital in nature. And as the ophthalmoplegia sets in, the headache starts to diminish typically. The pupil is involved and the diplopia or the ophthalmoplegia resolves within several days to a few months. Recurrent episodes may occur, and if they do occur, they may cause permanent deficits. And imaging during the attacks may show nerve root enlargement and enhancement. We must remember that ophthalmoplegic migraine is a rare entity and is always a diagnosis of exclusion, and we have to first exclude other causes of a pupil-involving third cranial nerve palsy before we can label a case as ophthalmoplegic migraine. Ocular neuromyotonia usually follows skull radiation therapy, and neuromyotonia may set in months to years following the radiation therapy, and it may affect any of the ocular motor nerves. Ocular neuromyotonia is characterized by episodic diplopia, and the episodes are usually very short lasting, usually 30 to 60 seconds, and occur particularly when the involved nerve is activated by the patient, which leads to sustained contraction of the supplied muscle. So in a 6 cranial nerve neuromyotonia, on attempted ipsilateral gaze, there will be sustained contraction of the lateral rectus muscle, resulting in exotropia with attendant diplopia. And similarly, in a 3rd cranial nerve neuromyotonia, there can be esotropia, reduced elevation and depression, and the pupil not reacting to light or near. Aberrant regeneration can also occur in a 3rd cranial nerve neuromyotonia. Ocular neuromyotonia usually responds to medical therapy such as carbamazepine. Till now we have discussed mostly single cranial nerve involvement. Now we come to multiple cranial nerve involvement, and the multiple cranial nerve involvement can be only on one side or unilateral, or can be on either side, that is bilateral. Unilateral multiple cranial nerve involvement usually occurs from cavernous sinus and orbital apex lesions. Bilateral multiple cranial nerve involvement can result from inflammatory lesions such as Guillain-Barré syndrome, from infiltrative lesions such as carcinoma or leukemia, or midline compressive lesions such as chordoma, nasopharyngeal carcinoma, or chondrosarcoma. And cavernous sinus lesions can become bilateral because the two cavernous sinus are interconnected by venous channels through the sella. As we have seen, lesions on the clevus or the posterior aspect of the sphenoid bone may affect both the cranial nerve 6 as they lie close to each other in this region. A cavernous sinus lesion may involve the 3rd, 4th and 5th cranial nerve lying in the lateral wall of the cavernous sinus, and also involves the 6th and the sympathetic supply which lie within the cavernous sinus, the 6th cranial nerve and the sympathetic along with the carotid artery. The nerve which is involved earliest in a cavernous sinus lesion is usually the 6th cranial nerve, which lies within the cavernous sinus, and it may be the only one to be involved in a cavernous sinus lesion. Venous congestion also occurs in cavernous sinus lesions and may present as orbital and conjunctival venous congestion and raised intraocular pressure. Pain is a prominent symptom due to involvement of the 5th cranial nerve. Involvement of the 2nd cranial nerve signifies involvement of the orbital apex and or the superior orbital fissure. This is because lesion involving the cavernous sinus only usually does not involve the optic chiasm or the optic nerve. That is because they lie above the cavernous sinus, but the optic nerves and the other cranial nerves run together in the region of the orbital apex or the superior orbital fissures and may become involved simultaneously. Causes of cavernous sinus syndrome and or orbital apex syndrome includes neoplastic lesions, aneurysms of the internal carotid artery within the cavernous sinus, inflammatory lesions, infectious lesions, cavernous sinus thrombosis, and carotid cavernous fistula. These two entities we will be discussing as separate topics in later sessions. Workup includes neuroimaging and CSF analysis. A CSF analysis may help us by revealing a neoplastic process, an infectious process, or an inflammation. This picture shows a left-sided cavernous sinus thrombosis, and we can see that the left cavernous sinus is dilated as compared to the right cavernous sinus. And this picture shows a patient with a right-sided carotid cavernous fistula, and in this situation we find arterialization of the venous channels of the conjunctiva. Other causes of diplopia can be from orbital lesions, from disorders of the neuromuscular junction such as myasthenia gravis, or from muscular disorders such as congenital muscle dystrophies. Treatment of diplopia, whether arising from an ocular motor nerve lesion or from a more peripheral lesion or from a supranuclear lesion causing diplopia, includes treatment of the primary cause if possible. And then we should also manage the diplopia. Acutely we can manage the diplopia with occlusion or frosted glasses in the affected eye and botulinum toxin injection to the antagonistic muscle. When the diplopia becomes chronic and committant, that is, the diplopia or the divergence is the same in all directions of gaze, we can use prisms to manage the diplopia, and when the ocular deviation remains stable for 6 months or more, we can plan surgery to correct the strabismus. So we are going to end this session with some differential diagnosis lists. So causes of painful ophthalmoplegia include trauma, aneurysm, carotid cavernous fistula, cavernous sinus thrombosis, infections, inflammation, tumors including pituitary apoplexy, and ophthalmoplegic migraine. Differential diagnosis of either a third nerve palsy or a fourth nerve palsy include myasthenia gravis, restrictive myopathies, and skew deviations. Skew deviations come in the differential diagnosis of the third and the fourth cranial nerve palsies because these two nerves supply cyclovertical muscles. Differential diagnosis of sixth cranial nerve palsy includes myasthenia gravis and restrictive myopathies. Skew deviation does not come in the differential diagnosis of sixth cranial nerve palsy because the lateral rectus muscle supplied by the sixth cranial nerve is not a cyclovertical muscle. The other differential diagnosis of sixth cranial nerve palsy include Duane's syndrome, spasm of near reflex, and decompensation of a prior esophagia. In Duane's syndrome, characteristically there is a globe retraction and the patient usually does not complain of any diplopia, and in spasm of the near reflex the patient retains his or her ability to abduct one of the eyes when the other eye is closed. Differential diagnosis of a patient with multiple cranial nerve involvement includes myasthenia gravis, restrictive myopathies, and skew deviations. Differential diagnosis of multiple cranial nerve involvement also includes CPEO, also known as chronic progressive external ophthalmoplegia, and Wernicke's encephalopathy. Thank you for listening.